Management.
Thank you. I am crazy. But I like Utah. It's great here. Great weather, especially when it's like this. So, last talk of the day. We'll get you out at 5. Don't worry about that. I'd like to thank the Ogden Medical Surgical Society for inviting me here today to give you this talk today on dietary changes that can slow chronic kidney disease progression. Now, whenever I'm in the office and I hear a dietary talk, I always think, what did I just eat? Sometimes I feel guilty, so maybe, we'll bring some awareness to our own personal diets here. Okay, so I have empty pockets. The objectives today, I'm going to give you a brief overview of chronic kidney disease. I'm going to talk to you about some promising dietary intervention strategies that might slow chronic kidney disease progression. The two I'm going to focus on today are dietary acid ingestion and fructose, which is a huge problem in the United States. And then finally, I'm going to give you my own personal dietary recommendations for CKD patients and try to convince you that what you're probably already telling people with CKD and even your non-CKD patients is a good thing, that you're already doing the right things. So chronic kidney disease is typically diagnosed based on the glomerular filtration rate, or the GFR, when it's less than 60. Or you can have chronic kidney disease if your GFR is more than 60, but you also have evidence of kidney injury. And so some examples of that are albuminuria that's more than 30 milligrams per gram, which is very common in diabetics. So a diabetic patient who has a GFR of more than 60, so for example 80, could still have CKD if they have albuminuria. Other examples include polycystic kidney disease and glomerular hematuria from something like IgA nephropathy. Now, how do you know if there's glomerular hematuria? It really relies on a nephrologist looking at the urine under the microscope and finding dysmorphic red blood cells or red blood cell casts. So in the primary care clinic, you're probably not going to be able to be sure that a patient has glomerular hematuria. It'll be something that the nephrologist has to identify. Okay, so in the US, the most common causes of chronic kidney disease are hypertension and diabetes, but there are other common things that we see in nephrology clinics, such as cystic kidney disease, such as polycystic kidney disease, which is an autosomal dominant condition in adults and an autosomal recessive form in children. There are other types of cystic kidney diseases as well. Glomerular nephritides, of which there are a number of them, interstitial nephritis, which can be due to chronic infection or NSAID use, reflux, which is seen in kids mostly, and obstruction, such as from BPH. All right, so there are 5 stages of CKD, 1 through 5. Whoops, how do you go back? There we go. 5 stages of CKD based on the level of the GFR, with stage 5 being the worst. Stage 1 patients have a GFR that's more than 90, stage 2, 60 to 89, stage 3, 30 to 59, stage 4 is 15 to 29, and stage 5 is less than 15. Now, most patients with stage 5 CKD are going to be on dialysis or need a transplant in order to survive. So why should we care about this? Well, there are a lot of Americans in the US who have CKD. Most people, gosh, I gotta get this right here, okay. Most Americans with CKD, about 15 million, have early stages of CKD, stage 1 and 2, when the GFR is considered to be normal, but they have other features of CKD, such as albuminuria. About 10 million patients have stage 3 CKD, and about 1 million people in the US have more advanced stages of CKD, stage 4 or 5. So why, again, should we care? Well, compared to people who don't have CKD, people who have stage 1 and stage 2 chronic kidney disease have a mortality risk that's twice as high. And as you get to more advanced stages of CKD, that mortality risk goes up. So it's 25% over 5 years for people with stage 3 CKD, 50% over 5 years for those with stage 4, and then for those on dialysis, it's about 20% per year. So the average life span of a patient on dialysis is about 5 years. So it's really a big problem in the US. All in all, about 25 million Americans have chronic kidney disease, which is 12% of the population. And based on the previous slide, what I've tried to convince you is that advancing CKD leads to poor outcomes. For those who have advancing CKD that progresses to end-stage renal disease, it is also very costly to the economy. So of the 600,000 patients on dialysis, they account for 6% of the Medicare budget, which is a hugely disproportionate amount. And for those who do require dialysis in order to survive, we would love for them to get transplants because that improves their quality of life, likely improves their survival. However, transplantation is a very scarce resource. So the main job of the nephrologist is really to try to slow progression of chronic kidney disease. And to date, there are really only 3 strategies that have proven effective. One is giving patients ACE inhibitors or ARBs. The second is controlling blood pressure, and the third is controlling glucose. But above and beyond that, that's really all that we have. So we need other strategies that are going to be helpful for patients. So if your patients are like mine, they hear there are only these 3 things that can be done. They ask me, what can I do? And the things that they always ask me are, will diet help me? Will exercise help me? And will vitamins or supplements help me? Now I'm going to talk to you today about diet. I do generally recommend exercise for CKD patients, but for vitamins, I'm not really certain that they're of any benefit. So on to the dietary portion of the talk. Okay. So first I'm going to talk about dietary acid. And I also want to mention here that all of these studies and recommendations that I'm telling you today are in non-dialysis patients, okay? And I also want to mention that there are other potentially beneficial dietary recommendations, such as restricting sodium intake, such as what Dr. Stoltz was talking about, as well as restricting phosphorus. But today I want to focus on some newer concepts, okay? So dietary acid is the first one. Okay. So a major function of the kidney is to regulate the body's pH. The average acid burden that the kidney must get rid of on a daily basis is about 1 milliequivalent of acid per kilogram per day. So if you weighed 70 kilograms, you would have to get rid of 70 milliequivalents of hydrogen ion every day in order to maintain acid-base balance, all right? Now, what I'm talking about here are non-volatile acids, as compared to volatile acid, such as carbon dioxide, which is blown off by the lungs, okay? So the kidney deals with the non-volatile acids, the lung deals with carbon dioxide. So what are the sources of non-volatile acid? The first is diet, and a large component of the dietary acid that we ingest comes from protein. And of the protein sources, red meat gives us the most acid, fish gives us sort of an intermediate, as well as poultry, and then plant-based proteins really have the least acid generation. There are other things in the diet that are acidogenic, so to speak, and I'll show you some of those examples a bit later. Apart from diet, there is endogenous production of acids, such as from keto acids and lactic acids, just from normal cellular metabolism. Okay? So, when you eat your hot dog or whatever it is you're gonna eat, okay, the kidney's gotta get rid of this acid, all right? Get rid of it in the urine. And the way that it does that is by increasing ammonia production in the tubular cells, okay? That ammonia complexes with the hydrogen ion to form ammonium, which is then excreted in the urine. This is the extent of the physiology for today, okay? But this is important, all right? Because that hot dog does 2 bad things, all right? First, by increasing ammonia production, it's been shown in animal models that high levels of ammonia production in the kidney causes intrarenal complement activation. The other thing that happens is endothelin-1 levels go up in the kidney, and the effect of endothelin-1 is to help secrete acid into the urine, all right? Both of these things lead to kidney injury, okay, which in a patient with CKD can worsen chronic kidney disease and lead to CKD progression. Okay? So an important question to ask yourselves here is, does reducing the renal acid burden slow CKD progression? Before I get to the diet, though, I want to talk to you about sodium bicarbonate, because this will give us some background about how the diet can also be helpful. So sodium bicarbonate is an alkaline agent, neutralizes acid, okay? It's commonly used. It's typically prescribed in CKD patients when the serum bicarbonate concentration falls to less than 22 millimoles per liter. And the reason that we treat people with sodium bicarbonate in this setting is because of theoretical benefits on preventing bone demineralization as well as reducing the protein catabolism. Both of these result from metabolic acidosis, okay? So this is what we've been doing for the past 10 years. But in 2009, this very interesting study came out which showed us that correcting acidosis with sodium bicarbonate may actually slow CKD progression. This was a study of 134 patients in England who had moderate to severe CKD, stage 4, and they had metabolic acidosis. They had bicarbonate levels between 16 and 20. Half of them were assigned to get sodium bicarbonate, the other half to control. And when you look at dialysis-free survival, those patients who were on sodium bicarbonate had a much lower risk of progressing to dialysis over a 2-year period, okay? So these are in patients with advanced CKD and metabolic acidosis. But most people don't have acidosis and they would otherwise not benefit from sodium bicarbonate based on our current treatment practice. But interestingly, sodium bicarbonate seems to work in people with earlier stages of CKD who also have normal serum bicarbonate. This was a study of 120 patients who had stage 2 CKD, so their GFR was between 60 and 90, but all of them had normal serum bicarbonate concentrations. A third received sodium bicarbonate, a third placebo, and a third received sodium chloride. And what they found was that over 5 years, those people in the sodium bicarbonate had a higher GFR compared to the other two groups. So this information suggests that even patients with normal serum bicarbonate might benefit from sodium bicarbonate. Okay, so to summarize sodium bicarbonate reduces the acid load to the kidney because it's an alkaline agent. It reduces renal ammonia production, which I told you activates the complement system. And when you give sodium bicarbonate, it reduces complement-mediated injury. Sodium bicarbonate also reduces endothelin-1-mediated kidney injury, and it appears to slow CKD progression. Now, we do need larger studies to confirm this, but this is some very exciting progress in our field, okay? So the question then becomes, can we reduce dietary acid load? And the obvious answer today is that yes, we can by reducing protein intake and increasing fruits and vegetables in the diet, okay? So let's talk about low protein diets. The benefits of low protein diets in patients with CKD are multiple. It better controls acid regulation, better controls phosphorus, which is a significant problem in lots of CKD patients, better control of blood pressure, reduces proteinuria, and enhances insulin sensitivity. So these are the theoretical benefits of low protein diets. However, there are disadvantages. It can lead to protein energy malnutrition, decreased muscle mass, and it's very inconvenient for patients. So a lot of you may know already that, or have practiced in a time when low protein diets were basically recommended for everybody. But that recommendation has largely fallen by the wayside, largely because of the results of the MDRD study, which Dr. Stoltz alluded to in regards to blood pressure. So this MDRD study, the main goal of this study was to determine if a low protein diet was better than a usual protein diet in moderate CKD. It's perhaps now more famous for giving us the MDRD formula to estimate GFR, but one of the main components of this study was to look at the effect of protein, okay? So these are the main results from that study. This was published way back, 1994. And what they found was at the end of 3 years, there was no difference in GFR between the low protein group and the usual protein group. So this was the focus of the result, that low protein diets were not beneficial in patients with CKD. But over the years, but after the study came out, what the investigators noticed was that there was an acute reduction in GFR with the low protein diet. So in the first 4 months, GFR markedly reduced in patients on the low protein diet. But if you follow them from here on out, you can sort of see that their slope is less steep than in those who receive the usual protein diet, which suggested that, hey, maybe if we follow these patients for a longer period of time, we might see a benefit with the low protein diet. And indeed, that's what they found. Although it wasn't statistically significant, these are the follow-up data of up to 10 years for these patients. And what they observed was that those in the low-protein diet had a lower risk of end-stage renal disease or death compared to those in the usual protein diet, okay? Now, I should mention here that there was a second protein component in the MDRD study. This portion of the study, the main question was whether or not a very low protein diet was better than a low protein diet in patients with more advanced CKD. These were patients with stage 4 CKD. And what they observed was that the percentage of patients who developed end-stage renal disease or died during the follow-up period was lower in the very low protein diet compared to the low protein diet. However, if you look at the long-term follow-up data, patients in the very low protein had a higher risk of death, okay, compared to those on the low protein diet. So it's giving us a little bit of, conflicting data here. So to summarize low protein diets, the clinical trial results, number one, very low protein diets are very bad, okay? So avoid very low protein diets in your CKD patients. Modest protein reduction is possibly beneficial, although we're probably never gonna do another randomized controlled trial looking at the benefits of a low protein diet. So we'll just have to take our intuition and our own opinions on this matter when it comes to low protein diets, okay? And one of the mechanisms might be by reducing renal acid burden, okay? So my personal recommendation is to reduce protein intake by 25%, which is usually just telling people don't go back for seconds, okay? Because that is the percent reduction that was achieved in the patients who were in the low protein diet group compared to those who received the usual protein diet. They had a 25% reduction. I ask patients to eat less red meat and to consume more poultry, fish, egg whites, and plant protein, such as quinoa, soybeans, lentils, and beans. And if you have a hard time remembering that, just remember the Chick-fil-A cows, okay? They like this. They like me. Okay, so that's low protein diet, okay? Now we're gonna move on to fruits and vegetables, okay? So most fruits and vegetables are alkali forming, okay, other than cranberries. And you might think, wait, citric acid. What's interesting about citric acid is that gets converted to bicarbonate, so it's actually base forming, okay? So most fruits and vegetables are alkaline, so let's see if there's any data. There was one study, which was an interventional study of fruits and vegetables in 70 patients with stage 4 CKD, okay, GFR 15 to 29, and they had low serum bicarbonate, less than 22, and importantly, their potassium was less than 4.7 because they were worried that potassium would go up, right, when you consume fruits and vegetables. The intervention in the two groups were either sodium bicarbonate at a dose of 1 milliequivalent per kilo per day, or fruits and vegetables designed to reduce the acid load by about 50%. The main question that they asked in this study was whether or not fruits and vegetables could correct the acidosis, so bring the bicarb up into the normal range, okay? So you might ask yourself, what are some of these fruits and vegetables that they gave these patients, and how did they do it? So these are the lists: apples, apricots, oranges, peaches, pears, raisins, strawberries, carrots, cauliflower, eggplant, lettuce. Potatoes, sweet potatoes are a little bit better, spinach, tomatoes, and zucchini, okay? So how do you get patients to eat lots of fruits and vegetables? Well, you give it to them for free, which I thought was very smart for these investigators to do. Now, these patients were patients who were poor. So what they were worried about was that when they gave these patients all these fruits and vegetables, that they would just go ahead and share their fruits and vegetables with other family members. So they were smart in another fashion. They gave enough food for all the family members in their household so that they wouldn't share, so that they would have enough fruits and vegetables so that they could test the benefits of this diet. And very remarkably, all of this food was provided for free from the local food bank. So I think it's just very inspiring how you can do some of these clinical trials. So what did they find? Well, as expected, if you calculate their estimated dietary acid production intake using dietary questionnaires, those patients in the fruits and vegetable group after 1 year, they had lower dietary acid ingestion compared to those on bicarb. Bicarb didn't change their diet, it just reduced the renal acid load to the kidney, but the dietary intake of acid was still the same, okay? And what their main question was, can it correct acidosis? And yes, it can, okay? So the bicarb came up from less than 20 up to about 20 and a half. There was a modest increase, but the trend was that there was an increase here compared to the bicarb, okay? So that's not really exciting. But what I do want to point out here that's important for CKD progression is that the bicarbonate and the fruits and vegetables both reduced urinary albumin excretion, which is a good prognostic marker. If you have a lowering of urinary albumin, it is a good prognostic marker for CKD, okay? The other important observation was that hyperkalemia did not develop in the fruits and vegetable group. And the reason for this is if you correct the bicarbonate, the potassium will come down. And so no hyperkalemia developed in this group, okay? So the results of this study showed us that augmenting the diet with fruits and vegetables does reduce the acid burden to the kidney, and it does ameliorate kidney injury by reducing urinary albumin excretion, which is a good prognostic marker. So my practical recommendation for patients with CKD regarding fruits and vegetables is, yeah, go ahead, increase the fruits and vegetables in the diet, okay? But I do caution you that if the serum potassium is more than 4.5, or if the GFR is less than 30, stage 4 or 5, you should monitor the serum potassium because the potassium might go up. Even though I told you that, you know, it really shouldn't, it's better that you just check it, just for your own safety and for the patient's safety. And if you do have an increase in the serum potassium, you can go ahead and reduce it with diuretics. Okay. So, before we leave the dietary acid part of the talk, I just want to give you a list of some of the alkaline and acidic foods that we eat, that we could potentially eat. Alkaline foods are green vegetables, garlic and onions, sweet potato, carrots and tomatoes, seaweed, most fruit, tea, quinoa, stevia, artificial sweetener, and apple cider vinegar. Now, when I show you this acidic side, it might shock you a little bit because our diets are very acidic. So low acid content foods are beans, peas, tofu, and edamame or soybeans. Chicken breast and fish, they do produce acid but less than red meat, and bananas. Now look at all this stuff. Alcohol, coffee, soft drinks. I noticed the pile of sodas out there. Okay, these are all acidic drinks. Cookies, cakes, pastries, beef, lobster, we don't eat that regularly. Artificial sweeteners, white rice and pasta, dried fruit, cranberry, mayonnaise, ketchup, and high fructose corn syrup. These are common things that we eat on a day-to-day basis, and our kids as well. Well, maybe not alcohol. Okay. So high fructose corn syrup, that provides us a nice segue into this portion of the talk, and Mayor Bloomberg's crusade against 7-Elevens and big gulps. So there have been some recent, there has been recent interest in fructose and its relationship with chronic kidney disease, largely because fructose is related with uric acid production, hypertension, as well as chronic kidney disease. This is apart from the high dietary acid that comes with high fructose corn syrup. Okay. So we turn to America's sweetheart, Honey Boo Boo, who can help us understand how fructose might be bad. Okay. Fructose produces uric acid, which induces inflammation and oxidative stress. It reduces nitric oxide production, which can promote kidney injury and lead to CKD progression. And there are probably other mechanisms that we're unaware of that also lead to kidney injury in CKD patients. Okay? The primary sources of fructose in the Western diet are high fructose corn syrup and table sugar, which is sucrose, which gets cleaved to glucose and fructose. Now, the average American consumes 64 pounds of fructose a year. 64 pounds. It's a huge amount. And in large quantities, systemic levels of fructose can be filtered by the kidney. And if you take rats, and if you remove one kidney and 2/3 of the other, and you give them a high fructose diet, you can see here that these glomeruli are just totally fibrotic. The interstitium here is very fibrotic, and the tubules are dilated compared to animals on a control diet. And animals who were given a dextrose diet or glucose diet really didn't have any major kidney abnormalities, okay? So these are CKD rats. Now what about normal rats? Okay, these are rats with intact nephron mass, so they have both kidneys. Again, if you give them a high fructose diet, look at what happens to the kidney architecture. These tubules are very dilated compared to the control, and there's a lot of fibrosis in here. Same thing goes with glucose here. It didn't really cause any kidney injury. So even in patients who don't have CKD, they might be putting themselves at risk for CKD with the consumption of high fructose corn syrup and other high fructose foods. Okay? Now what about in people? We don't have any biopsy data, but we do have data from NHANES. These are non-diabetic patients from NHANES, and what they looked at was the number of sugary soft drinks consumed per day and the prevalence of albuminuria, defined as a microalbumin to creatinine ratio of more than 30 milligrams per gram. And what you can see is that with higher numbers of soft drinks consumed per day, there's a higher prevalence of albuminuria. Now these are non-diabetic patients, so imagine diabetic or obese patients who are consuming colas or other things. They just looked at soda here, okay? They're not talking about pastries, cakes, those sorts of things. If you just look at soda intake, markedly higher levels of albuminuria, okay? And some people have gone so far as to say that the high fructose corn syrup diet that we are ingesting in this country has gone up, and it also parallels the rapid increase in end-stage renal disease prevalence. Okay? That's a good theory. I think it needs a little bit more work, but there is definitely something here that is worth considering. Okay? So what might a low fructose diet do in patients with CKD? This was a study in Poland. 28 non-diabetic patients with chronic kidney disease, stage 2 or 3. They had basal fructose intake levels of about 60 grams per day, which is consistent with the American diet. They were told to go on a 6-week low fructose diet, which was designed to reduce fructose intake by 80%. The only thing they told them to do was to reduce consumption of sucrose-sweetened and artificially sweetened drinks and foods. That's it. So they did that for 6 weeks, and then they returned to their basal diet for 6 weeks. Importantly, there was no difference in caloric intake during the entire period of the study. And what they found was, yes, okay, their fructose intake did go down and it did go up. And what they also observed was that uric acid levels, as well as blood pressure, uric acid levels and blood pressure went down during that initial 6 period, and it persistently stayed down. Okay? Uric acid and blood pressure remained low even after they resumed their basal diet. Now the study wasn't powered to look at effects on GFR or CKD progression, but what they did look at was urinary TGF-beta, which is a marker of kidney fibrosis. And what they found was that urinary TGF-beta levels did go down during the low fructose phase of the study, but went back up, suggesting that a low fructose diet may reduce kidney injury in CKD patients. Okay? So a low fructose diet improves uric acid, it improves blood pressure, and it may reduce renal damage by reducing urinary TGF-beta. There are no long-term interventional studies in CKD patients, but it's just not good for you, okay? That's really all you need to know. Not good for CKD patients. Okay, a few more slides and then we're done. So dietary recommendations for CKD patients. Our Western diet is terrible. It's high in red meat, it's high in processed meats, high in refined grains, high fat dairy ingestion, saturated in trans fats, high cholesterol, and sugary desserts and drinks. Dr. Stoltz mentioned the DASH diet. This is something that I like to tell my patients about as well. Consume more poultry and fish, consume more whole grains. If you like dairy, make sure it's low fat, monitor their phosphorus levels. Unsaturated fats, fresh fruits and vegetables. I'm sure these are what you're telling your patients anyway. But if you look at what the effect of a Western diet can have on CKD progression, this is data from the Nurses' Health Study, looking at the the risk of CKD progression defined as a GFR reduction by 30%. And the more Western-like your diet was, the higher your risk of CKD progression, okay? If you look at a DASH diet, the more dashier your diet, or DASH-like your diet was, the lower your risk of CKD progression, okay? So, just to summarize here, high acid and fructose cause kidney injury in CKD. The average American diet is way too high in both of them. And it is very sensible to increase fruits and vegetables, reduce animal protein intake, and eliminate sugary foods and drinks. Things I think you're already telling your patients. But these are some of the data that support that. You know, it used to be that I would tell these patients, do these things, but I didn't really know why, or if it would really be beneficial. But I think these data really can drive it home, okay? So these are my recommendations. Stop soda, stop fruit drinks. Those are high in fructose. Eat rare desserts, more fresh fruits and vegetables, monitor the serum potassium. I prefer patients eat fish and chicken breast. Plant-based proteins such as quinoa have lots of protein and are very healthy. Less red meat because of the high acid and the high phosphorus. Reduce the processed and canned foods. Again, low-fat milk, but monitor the phosphorus. And then consume a low-salt diet. And that's it. Time for questions. Oh, you know, like Splenda, those sorts of things. Yeah, the only artificial sweetener that is alkali forming is stevia.
I had a question that's basically the same thing, I think, and that is, I'm sitting here with 2 cans of Diet Coke in front of me. But I didn't understand why the fructose and the artificial sweetener have the same effect. But apparently it's because the artificial sweeteners are acid forming. Is that what you're saying?
Correct.
Okay, thank you.
Yep.
Question.
Yes.
What effect does exercise, such as walking or running, etc., vigorous people that are exercising, have on the diet in regards to the chronic kidney disease?
What effect does diet have on exercise?
No, exercise with relationship to diet. Are any studies that made up that way?
Not that I'm aware of, but I would assume that patients who are more likely to exercise are more aware of their diet and are more likely to just have a better diet in general. Does that answer your question? I don't know that there's any firm data on that, but exercise I think is good. You know, just monitoring their cardiovascular risk is always important.
Question about the sodium bicarb. Can you just give that to a patient?
Yeah.
In what form and how and
okay.
how much?
So sodium bicarbonate, you know, typically what we do is we wait until the serum bicarbonate falls to less than 22. And we give patients sodium bicarbonate. It comes in a tablet. It's 650 milligrams. Depending on how low the bicarb is, I would either start at twice a day, 650, or 3 times a day, and then monitor their bicarb over time. You know, the only time that you really need to get excited about the bicarb is if the potassium is high as well, so if it's over 5. In that setting, I'll be a little bit more aggressive, maybe 2 pills twice a day, because if you correct the bicarb, it'll bring the potassium down. So otherwise, I just sort of titrate it, you know, over monthly intervals. It takes a long time to replace your base in the body.
Okay, but we have a lot of people that take just the baking soda for like their indigestion. Is that doing any harm or is it doing any good?
You know, my personal bias is that I think sodium bicarbonate is going to prove to be useful to slow CKD progression, even in patients who have normal serum bicarbonate. Now, back to your question about how to dose it. I don't typically give it to people with normal serum bicarbonate levels because we don't have anything to titrate the medicine to. So then you're sort of left, well, I'll just give somebody 650 milligrams twice a day and cross my fingers and hope that that's good enough. So we really don't know how to dose it very well just yet. We have some studies that are ongoing that are looking at that.
Thanks, Kalani.
Thank you, everyone. Please fill out your CME forms and your evaluations, and see you tomorrow. Thank you. Thanks a lot.